Our inpatient oncology rehab service at Dodd Rehabilitation Hospital was the first in Ohio, second in the United States, and third in the world to be accredited.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Whitney Luke. Whitney is the Medical Director of Oncology Rehabilitation at the James, and she is the Chair of the Department of Physical Medicine and Rehabilitation at The Ohio State University Wexner Medical Center. Cancer treatment saves lives, but surgery, radiation, and drug therapy can also create pain for patients. Whitney will fill us in on how she and her team are leaders in treating and reducing pain and how this can improve the quality of life and even the outcomes for patients. Welcome to the podcast.
Thanks for having me, Steve.
So this is a little bit of a unusual field to specialize in, and from what I understand, you're a bit of a pioneer in it. So fill us in on how you came to do what you do.
So I came here to do my residency in physical medicine and rehabilitation, which centers on functional outcomes. And as I was doing my residency here, at the time, we didn't have a dedicated service, inpatient or outpatient, for cancer survivors for cancer rehabilitation, which can include pain control as well.
So you would be seeing patients, all sorts of patients, but you decided cancer patients needed help.
Correct. So at Dodd Rehabilitation Hospital, which is an inpatient rehab hospital here on the medical campus, we take all kinds of patients that have functional diseases. So you could be somebody after a stroke or a spinal cord injury, but we often saw patients that had some kind of cancer-related disease as well. And I recognize that those patients may have a little bit of a differing need, not only pain control, but just functional outcome needs, rehab needs, and decided it would be great if we could start a program specializing in cancer rehabilitation.
Wow. So you're fairly new here, and you take the initiative to start a whole new program.
Yep. Yes. So I stayed for a year after my residency and developed our inpatient rehab program. And then I left to complete my interventional pain fellowship and came back and started growing our program outpatient as well.
So what is the name of this patient program?
So we really just call it Oncology Rehabilitation. Okay. We have a service inpatient at Dodd Hall, and then we also have our outpatient services and clinics as well.
Okay, so before we really dive into that and what you do, let's talk a little bit about the pain that cancer patients have, because, I mean, the levels of invasive surgery and radiation and drug treatment really vary. So what do you see in cancer patients? What's the range, the scope of pain?
So the range can be very differing for different people, and that's because pain is very subjective. We have patients that say, I have zero pain, I have minimal pain, and then you have patients with severe pain. And pain can be challenging to treat because lots of things can cause pain. You know, tumors and direct invasion of cancer can cause pain, but we can also have pain way later in cancer survivors from treatment, like chemotherapy or radiation. Often it's nerve-related pain, which can be a little challenging to treat as well. Just because there's limited things that you can try for pain. But pain really affects people's quality of life and also just their functional outcomes, the things that they want to do with their family or the exercise they want to do. Pain really can kind of worsen, those areas and allow people not to be able to participate in the things that they want to do.
And it seems like it can become a vicious cycle that if you have pain, you do less things, and the more inactive you are, your pain can get worse.
Correct. And that's the hard part, right? When you don't feel good, sometimes you don't want to do a lot of exercise or activity, but then the longer you don't do things, it's harder to get back. Just like trying to, make a New Year's resolution, you're going to go back to the gym on January 1st. If you go that day and do tons of activity that you haven't been doing before, the likelihood that you'll go back is very low.
Oh, I thought you said the likelihood that you're going to wake up the next morning in pain
is very high.
Yeah.
Correct. Yes. So, and that's the hard part, right? Is finding exercise that people can participate in and keep participating in while they're having pain can be challenging, and also just getting people to buy in that the more you exercise, often we do feel better.
Yeah, keep moving is a key. Can pain also, or the impact how people are treated and their outcomes? If they're in pain, they might not be able to tolerate as much treatment.
Correct. So functional status is very important, and performance status for treatment options for patients with cancer. And so if patients are in severe pain, they haven't been doing very much, the performance status can be lower, which can then alter the options that are available to them. Chemotherapy, radiation can be sometimes hard to tolerate. So if we're very deconditioned, the tolerability of some of those treatment options might be lower.
And can some people just, for whatever reasons, tolerate pain better than others?
They can. Yes, and it's true. Some people have very high pain tolerances and some people have very low pain tolerances. And so it varies from everybody, person to person. And there are some patients that have, metastatic cancer that you see their image and you think, I would imagine they have a ton of pain. And when you talk to them, they're working full time. They hardly take pain medications. It's very interesting how that can be one person and then someone else, their pain level can be very, very high. And we don't always know the reasons for that.
Do some people, in a sense, it's psychological, not that the pain is psychological, but they're just so determined to get on with their life and do things that they're better able to handle the pain and just ignore it?
I think coping skills can be one of the factors of how people tolerate pain. Some people just cope better than others. And you're right. It affects our psychological well-being in a lot of ways too. And there are some people I think that can just work through pain better than others. And it's not that they don't have pain. It's how they can deal with that pain.
Yeah, because constant pain is debilitating and can cause depression.
And pain affects your mood, your sleep.
Yeah.
When we're not sleeping, when our mood's lower, our pain is often higher too. So it is really important, all these symptom management areas, that we're managing all of it and just not focusing only on the pain aspect.
Okay, we're going to take a quick break, and when we come back, you'll fill us in on the specifics of what the rehabilitation clinic does for patients.
Great.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Whitney Luke, and let's dive into this program that you have created, which is one of the first in the entire country, if I'm correct.
Correct. Our inpatient oncology rehab service at Dodd Rehabilitation Hospital was the first in Ohio, second in the United States, and third in the world to be accredited.
So you are a pioneer.
Potentially, yes.
Oh, you're being modest. She's a pioneer.
So our inpatient program at Dodd is accredited, and it comprises a team just like our other service lines there do. We have a physician who leads that team. We have therapists, both physical, occupational, and speech therapists. We have case management, social workers, and then our resident team as well. We also have psychologists that play a very large role in that team, helping with coping with new diagnoses of cancers, what that means, what that may look like going forward. And really our goal is to improve functional outcomes so patients can tolerate more treatment or, maybe are debilitated after their surgery or their treatment. And really the goal is to get them home. And in outpatient, our clinics are embedded in our survivorship service line. Our survivorship service line does offer other things other than cancer rehab, including like massage therapy, sexual counseling, psychology counseling. But in my clinic, we have PT and OT on the floor with us.
PT is physical therapy, occupational therapy.
Correct. And speech therapy on the same floor as our clinic. We work very closely with our palliative care teams who do a lot of symptom management for our patients and really evaluating patients for maybe opioid sparing interventions for pain, injections, implantable devices that can help with pain. We also have a pain psychologist who sees all of the new patients on the same day that I do because, as I had said before, we really want to make sure mood, sleep, other things that can affect pain are being controlled as well. So really we see a lot of patients, to try and do, say, a patient with pancreatic cancer who has a lot of abdominal pain. there are interventions that we can try so that they don't have to take as many opioid medications that can have side effects. So really, it's a collaborative model. Get a lot of referrals from all kinds of the oncology teams. And really, our goal is how can we get patients feeling better, maybe taking less medications, and get them to their next treatment or get them to the functional outcome that they really hope to get to.
Boy, as you're going through all the different elements in your program, it just occurs to me once again that being part of a comprehensive cancer center and a large cancer hospital that has all of these specialists and experts is kind of what sets the James apart and makes you able to do what you do.
I could not have the program that I have here, and I'm so grateful to be a part of, because if we weren't at a comprehensive cancer center, we likely would not be able to fulfill the service line and provide the care to our patients that we do. So I always say, I'm able to do this here because of the James and because of OSU. I wouldn't probably be able to do this in a smaller place
You wouldn't
or
have the
a private.
experts.
I wouldn't have the team that I have, and so. This is kind of my dream job. I couldn't do it anywhere else. And so I love being here and working here.
So in a sense, you're kind of the coach of the team, and you put together and bring people in and sort of give them the tools they need to do a great job.
So I think the oncologist, obviously is the quarterback. But for me, pain, as we said, it can be all encompassing. And there's so many things that affect people's pain levels and their functional outcomes. And really, I think my job is to make sure we're treating all of those things. What can I offer maybe that someone else hasn't? And how can we all work together? And so sometimes it does take a lot of collaboration, a lot of conversations with different team members to say, is it okay if we try this? I really realized today, I think maybe we need to try, something else for their pain or their, psychological stress is really affecting them, and we haven't addressed that. So sometimes listening is often what I do more often than doing procedures. But, sometimes someone just needs somebody to listen to their whole story and maybe pick out something that we hadn't tried yet.
Yeah, listening is important. Well, let's talk about, and not by the I mean you, some of the different techniques you do, maybe some examples of different types of cancer and treatments and the pain that is caused and some of the new ways you do to reduce that pain, and even some things that are going to be coming up in the next few years, new things.
So we have a large variety of things we can offer. Things just as simple as a joint injection. So, for example, I often will see someone with sarcoma who's maybe had a resection in their leg, and now one leg might be longer than the other, and so they have some back pain or they have some knee pain, and it's really because of how they walk. So
now, a sarcoma is a bone cancer.
A bone cancer.
So something may have been removed, so their legs are different. Lengths. Okay.
Yep. Or they've had a knee replacement, right? And one leg is a little bit longer than the other. And so they may be having some back pain. So with therapy, we'll be working on their gait, but we'll say, hey, we could inject one of these small joints, like what's called an SI joint in your back, because that seems to be where your pain is coming from, and get relief. If somebody has...
What do you inject?
A mixture of steroid and anesthetic, which is a numbing medication.
And is that something that's one time only, or you have to do it every X amount of months?
So we see how long it lasts. We hope, it'll last months, and you could repeat it every 3 to 4 months and see. And that's when I think a lot of these interventions, it's important to have a detailed physical exam to figure out where is your pain coming from so that we're treating the right thing. We do epidural steroid injections. So someone may have cancer to the spine and have like a pinched nerve running down their leg. So you can do an injection with steroid again, targeting that nerve root to see if you can help like their sciatic leg pain. We do more invasive techniques, things like spinal cord stimulation, which is an implantable device that can help with nerve pain in different areas. We also do...
Is that electrical stimulation? Because I know that from a little bit of my sports career. They put those electrical pulses on you. This is not the metal rod they do on the outside of your body. This is implanted inside, and electrical impulses go out on a regular basis.
Correct.
Wow.
So there's the peripheral stimulation, like you're talking about, like a TENS unit that you can put on your shoulder or your neck. That works really well for certain things.
Things that are close to the surface.
Correct. So, but patients maybe have had back pain and they still have sciatic leg pain. We can use a spinal cord stimulator for that. Doesn't always have to be cancer related. We use it in chronic pain as well. Sometimes people will have invasion of nerves, you know, in the leg in different kinds of cancers like metastatic cancer. You can use spinal cord stimulation for pain coverage of that as well. There's also something that we do called an intrathecal pain pump. So if patients have pain and it's maybe somewhat controlled with oral medications like opioids, but they're not able to tolerate higher doses or they're having symptoms from them, sometimes we can implant a device called an intrathecal pain pump to get better coverage of that. And really what that means is if you're not having to take the medication by mouth, then you're bypassing, right, your gut and your stomach where you have to break down that medicine before it goes up to our blood-brain barrier. We can have the medication go directly into the spinal fluid up to the brain. So you have to use much less doses, much less side effects for that. Yeah, and I partner with our neurosurgery team. They will implant the pump devices for us, and then I'll manage the medications in them. So again, back to a team approach for how we can manage some of these things.
What different medicines would go in that pump?
So there are a couple that are FDA approved. The main two is morphine and the other one is Dilaudid, which are both opioid medications, but we mix them with an anesthetic, bupivacaine. And really that anesthetic we find is what really helps with pain control. Kind of like if someone's getting a hip replacement, right? They may have a nerve block, right? That's the same anesthetic that we use for that, and really makes sense why we can get better pain relief with less opioids because we're mixing it with that anesthetic.
Wow. Okay, what else?
So those are the main things we have now. There are nerve blocks, right, where we can burn nerves, what are called ablations. We can burn them with heat, like thermal heat, or we can use a chemical like alcohol. So there are bundles of nerves throughout our body that do different pain sensations to different areas. So one big one that we see a lot here is pancreatic cancer. We have a very large team, a GI oncology team. And so those patients have a lot of abdominal pain, and we can actually go in. It's not invasive at all. We use an x-ray machine for guidance and needles to guide us. We can numb up the bundle of nerves that does pain sensation to some of the organs in the abdomen, and then we can kill it off with alcohol. And often patients can get relief for up to 6 months with that. And then nerves do regrow. And so we can always repeat that procedure.
Now, if I'm remembering correctly, oftentimes with pancreatic cancer, that's a pretty invasive surgery. And is that part of the reason why there's that pain, and then you would do that procedure you just said?
Sometimes surgery, but oftentimes no surgery. But we do know there are a lot of blood vessels. There are a lot of nerves right there near the pancreas. And then often the tumor can grow into that area or more into the abdomen itself, irritate the lining of the abdomen, which can be very painful. And so that's when we would do that procedure. It's called a celiac plexus neurolysis. They don't have to have surgery before. It kind of depends on their pain. Often patients do have a lot of belly pain, worse with eating. You know, they may have some nausea associated. And often if they're, nauseous and you're trying to take oral pain medications, they may have a lot of side effects. So this is a good procedure to try to see if they can get their pain better, but also have to use less medications for that.
Wow, it sounds like what you do to nerves to sort of, I don't know, is destroy the right word? You have to be careful, and it becomes almost like an art form, and you have to be an expert to know how far to go and to not go too far, because if you go too far, I'm guessing that could create problems.
Correct. So we use some kind of guidance. Most of the time we use an x-ray for guidance. You can use ultrasound or CT guidance sometimes too, but you are correct. You want to make sure you're exactly where you want to be because you don't want to harm any other organs or other nerves that may do a different function than just pain. So I would say that procedure, the celiac plexus nerve block, is one of our more challenging ones. But once you've done it quite often, you become pretty good at it.
But again, you have teams of experts, not just one or two, but many, who do this on a regular basis and know exactly what to do.
Correct.
Yeah. is there anything coming down the pike that's in clinical trials or research now that is going to be helping patients down the road?
So they are working on different things. We've looked at for, just in chronic back pain, things that may also affect cancer patients, things directly to the discs that can cause pain and pinch nerves. We haven't had the greatest success, but there are some things we're looking at, like long-acting pain medication into that intrathecal spinal fluid space. Can that help? Cancer is challenging, right? Because there's no prediction of where it's going to go, how is it going to progress, what does it affect. So hopefully, there's going to be more things coming up in the next 10, 15 years that are kind of like along the lines of the spinal cord stimulation, using maybe neuroablative techniques that some of our neurosurgery team here, we work together for patients that have a shorter prognosis to their disease state. Can you do like ablations in the brain in the areas that provide pain
Ablations
relief?
is when you burn.
Burn.
Yeah.
Mm-hmm. Same as a chemical ablation, right? Killing off nerves or areas. So I think there are things coming, right? But it does often take grant funding and also long-term outcomes to see how long do these things last? Is it safe? So very interested to see what we can come up with in the future.
As you were talking about back pain, I think there's a big overlap between cancer patients and non-cancer patients, because doesn't some very high statistic percentage of people have back pain? Isn't it like 30 or 40? Right? Or like lots of people have back pain for lots of reasons. And you don't just see cancer patients, you see everyone with back pain.
Yes. So, the numbers keep growing, right, of cancer survivors. So we see larger number of patients who are in remission or living longer with cancer, right? So they have a lot of pain that may not be related to cancer, right? Just getting older.
Yeah.
And then patients even without cancer, chronic back pain is kind of one of the number one contributors for unemployment, not returning to work and functional activities. So some of these procedures we use for patients that don't have cancer as well. And it can be very challenging because we're living longer than we have before. Our bodies weren't meant to be 100 years old.
I know. I think our backs were only meant to be about 50.
Yeah, correct. Maybe 40 in some cases. And so what can we do? We can't really prevent arthritis from happening. The things we know that help is staying as active as possible, weight control. There's, the same procedures we can try, injections, ablations, things like that for pain control. But also really important in that regard to find new ways of treating pain that aren't medications that can allow people to have better, pain control, but return to the functions, work, activities that they want to do.
As you were saying that, it occurs to me that part of this, particularly with the physical therapist and occupational therapist, is helping people, particularly people who may not have exercised much, is teaching them how to exercise to build strength and flexibility, which can reduce pain.
Correct. Just really conditioning, improving your conditioning, your ability to exercise longer is one thing. For patients with cancer, maybe they aren't going to be able to walk longer distances. So then we also want to find assistive devices to help them with that. Maybe getting them the right power wheelchair or power scooter so that they can participate still in those activities. But they can't walk, right? So I have some patients that love going to concerts, but even parking in the handicap spots is still a far walk for them. So prescribing power scooters for them or a power chair so that they're able to still do those activities. Even just, our occupational therapists work on, dressing, maybe assistive devices. If it's hard for you to bend over to get your socks on, there's things we can use to thread your socks, get them on your foot without you having to lean over. So therapy has lots of tools for things besides just exercise and exercise guidelines that they can help us with.
People are pretty adaptable and can overcome a lot of problems, I've seen.
Yep. And we've learned that, right? If someone's right-handed and they have a stroke, or they have a brain tumor, you can learn to use your other hand, and before that you would have thought like, I can't use my left hand.
Even with writing?
It may not look as great, right? But, typing now, right? Yeah. There's so many communicative adaptive devices, right, that we can use our brain computer interface, right, that you can tell the computer and it can type and read for you what you want to say. So yes, we can adapt. Neuroplasticity of the brain is so cool. And I think that might be a wave of the future too for pain.
Oh, neuroplasticity is something I know a little bit about, and how you can retrain your brain to overcome trauma, to overcome, to learn new things, to just, it's a really fascinating and somewhat new science.
Yes, we don't know everything about it, but we do know, right, if you do something over and over again to retrain your brain, that it can be retrained, that other side or that other area we're using. And pain is one of those things. Sometimes stopping the cycle of pain can help us decrease pain even after that. It is really cool, I think, what's coming up and what we may see in studies and outcomes, just to see what can we do with that.
So obviously, you're a pioneer and a leader in this, and you created something when there wasn't something. What motivates you to kind of go above and beyond for patients here?
So I think, like I said, I'm so extremely grateful and lucky that I am able to work in a place that allowed me to begin and grow a program like this. And really just the patients are kind of the reason. When you can see a patient come in, in severe pain, and we're able to improve that for them, and they come back to you and say, I was able to go to my daughter's wedding, or I really wanted to, go on this vacation and it was great. That's, I think, the reason we do it. Personally, one of my very close friends in medical school was diagnosed with breast cancer and passed away at the age of 30. And just seeing what she went through and being able to affect change, I think, and help patients along their journey really is what, allows me every day to wake up and just be great that I have the job that I have.
So she still inspires you to keep going.
She does, yes.
That's a great tribute to her and an example of your determination.
So. Yes, I think, think about, how lucky we are. And when I see patients that have had devastating, cancer diagnoses, and they're the ones that are determined every day, so I think we're here to do what we can help them along their journey.
Caregivers want to help.
Correct.
Thank you, and keep up the great work and helping people reduce and eliminate their pain.
Thanks for having me today.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.